Well, hello, everybody. This is Michael Levy, Associate Professor of Neurology at Massachusetts General Hospital and Harvard Medical School. It's a pleasure to join you again on the topic of coronavirus. It's not like you haven't gotten enough of coronavirus from the news. I'm sure you have. This is a topic that's of intense interest to everyone, including you all, everyone with NMO and everyone without NMO. But before we get started, I need to acknowledge the folks who are helping pay for this event, and it's from Viela Bio. So let me quickly thank them. This programming is made possible through a patient education grant from Viela Bio. Viela Bio is dedicated to development and commercialization of novel, life-changing medicines for patients with a wide range of autoimmune and severe inflammatory diseases, like NMO. Their approach to drug discovery is aimed at providing targeted treatments for improved outcomes for the thousands of patients who have few or no therapeutic options. For additional information about Viela, please visit vielabio.com. Okay, with that out of the way, this is a chance for me to just spill everything from inside my head about coronavirus on Facebook and for you guys to respond. And I don't know if I'll have access to any of the comments that are coming in, but if you do have any questions, comments, suggestions, I think you can post them, and I'll figure out how to get you to those answers. Okay. So what's the latest? The latest is that coronavirus is still a pandemic. We're still in the midst of it. From the news, I heard that almost 200,000 Americans dead, and the United States is not in the best position now to curb the numbers. Depends on which television program and which side of the aisle you're sitting on, but whether we're getting better and about to turn the corner, or whether we're getting worse and it's a sustained problem. I think in terms of the numbers, the numbers are still going up. So there's still 50,000 new cases in the US per day. There's about 1,000 dead per day on average, and that's not good. And so this is going to be an issue that is going to be with us at least, I'm predicting, for at least the next few weeks, if not months. And it may require that we get to a coronavirus vaccine before this is really nipped. Now, there is good news. I would say that the treatment for COVID has improved, whereas previously when I was assigned to duty in the coronavirus clinic in Chelsea, Massachusetts, which was a hot spot back in March, April, we didn't know really what the best treatments were. We would get a chest x-ray on everyone, and we'd see lots of infiltrates, and we'd recognize that coronavirus causes a horrible pneumonia, and it often impairs the ability to transfer oxygen. Patients would have to be hospitalized because of breathing trouble. We recognized all that, but we didn't know the best way to treat it. And if they had a super infection, an additional pneumonia on top of that caused by another bug, we were able to treat that. We gave a lot of people antibiotics, but of course, since the virus it doesn't respond to antibiotics, we knew that the antibiotics were really to manage the additional infections, not the coronavirus infection itself. But now we do have some thoughts on how to manage the virus itself. You've seen the news with remdesivir and dexamethasone, or any steroid, basically, to just quell the immune response that accompanies the infection. That's what the steroids are doing. The remdesivir is actually an antiviral, and the combination seems to be useful. And so the numbers of patients who are dying with coronavirus, although the absolute numbers are high because the number of infections are high, the mortality rate keeps dropping. Okay, so historically, I think we're seeing numbers, between 2 and 3% of all infections were mortal or fatal, but that number keeps dropping because we're getting better at treatment. Okay, so patients are being flipped over on their tummies, and even in the ICU setting, to get the mucus out and to improve breathing. We are a little bit more aggressive maybe in getting people on the right levels of oxygen and even ventilators if they need it to avoid any emergencies. So I think the good news is that we're getting better at the treatment, even though the bad news is that the virus is still difficult to control at this point. Okay, so a couple of the thoughts on my head. One is the coronavirus vaccine. Okay, so there are lots of companies that are competing to make the first vaccine. You may have seen the news that Russia claims to have a vaccine and that they're distributing it and using it. I have no data, zero, on the efficacy of that vaccine. I know that they're making patients who are injected with that Russian vaccine are making antibodies, which is a good sign. It means that the products that are being injected are at least inducing an antibody response. It's not the only type of immune response we want to see. We want to actually demonstrate efficacy in that after the vaccination, we want to see that those people are now immune to getting sick from coronavirus. And sometimes the way those studies used to be done is they would take a number of healthy volunteers, they would give them the vaccination, and then they would try to infect these people. Okay, and then these people would show whether or not they're resistant to the infection. That's not exactly ethical anymore, and it's not ethical especially with coronavirus because of the high fatality rate and recognition that there are complications like heart disease, infection of the heart muscle, and things like that. So these vaccine trials are not necessarily exposing the volunteers to the virus. I think it's going to be more of a question of, well, if you got the sham, then what percent of those acquired the virus through community spread versus those who were vaccinated, what percent of them acquired the vaccine through acquired the infection through community spread, and hopefully the folks with the vaccine had fewer infections. That's really going to be how we determine whether a vaccine is effective or not. I have not seen those numbers from the Russian vaccine, so I don't know if they've done that already and they know that it works, or if all they know is that they're making antibodies, which is a measure, a biomarker of immune response to the virus, and that they're hoping that because there's an immune reaction to the virus, that then if they would actually acquire the infection from community spread, they'd be able to fight off the virus as well. We'll find out. I think there's a lot of public reporting, a lot of public interest on this, so we'll find out how that's working in Russia. Meanwhile, in the rest of the world, we're all watching the different trials proceed. The one that was developed at Oxford University, that one had the most hope because they started work on that after the first SARS pandemic. Didn't end up becoming a worldwide infection, but the concern at the time was, well, these SARS viruses are very potent, and they wanted to protect against another SARS-like event, like this COVID infection. And so they started working on the vaccine a long time ago. Obviously, they didn't make the kind of progress we were hoping, as the first SARS pandemic happened in, I think, 2003, 2004, and the Oxford group still hasn't come out with a vaccine, but nevertheless, they had everything ready to go. And so I think, were the first to reach a phase 3 trial setting, and that was sponsored by AstraZeneca, which is a big pharmaceutical company in the UK. And they announced that they had one complication that briefly paused the trial, and the complication was transversemyelitis, which to us, we all knew what that was because many of us have experienced transversemyelitis or read about it on Facebook, but a lot of people in the world are like, transversemyelitis, what is that? Even just yesterday, I believe, I spoke with a reporter at the Wall Street Journal trying to just explain what is transversemyelitis, why could that happen after a vaccine injection, and what are the ramifications of it, and then also what are the implications for people who are prone to transversemyelitis, like say you have NMO. Does that mean that this Oxford vaccine is off limits? So in the way I think about transversemyelitis, there are diseases that cause transversemyelitis, like NMO, like MOG, like multiple sclerosis. Then there are conditions that can predispose to it. So a one-time transverse myelitis attack often will follow an infection. That's well documented in the literature. And there's also evidence that sometimes after a vaccine, you might get an attack of transverse myelitis. In fact, if you go onto the US Vaccine Compensation Injury Board, you can search online for what are the how often does that happen, that after a vaccine you'll get an attack of transverse myelitis. These kind of things happen. There's a stochastic chance that after a vaccine you will mount a response to the vaccine, which will then look like something in the spinal cord, and the immune system then goes into the spinal cord and it surveils and it says, well, that protein kind of looks like that vaccine I just got, and so I think it's now foreign, and so then it attacks. It is a complication we are used to dealing with. There are other immunological complications that we've seen after vaccines. The most common is probably Guillain-Barré. It's a very, very similar one-time immune attack, but rather than going for the spinal cord, it goes for the nerves, the roots of the nerve, just as they come off the spinal cord, and that's called Guillain-Barré. Has slightly different manifestations, but it's often confused with transverse myelitis. And I would say Guillain-Barré happens much, much more often after a vaccine compared to transverse myelitis, but they're both on the list. Now, in any vaccine trial, I won't be surprised if we find one event of Guillain-Barré and maybe an occasional transverse myelitis. If this happens again, if there's a second patient in the Oxford trial with transverse myelitis after the vaccine, I would say, okay, that's more than just chance. There's something in their vaccine that's specific for the transverse myelitis, and we need to figure that out. A one-time event, I can dismiss. A one-time Guillain-Barré, or even twice Guillain-Barré, or one-time optic neuritis, or one-time transverse myelitis, among the general cohort of patients who are volunteering to receive the vaccine, I'm okay with that. That's not out of the ordinary. It's not scary. It's not unheard of. These are just immunological consequences of stimulating the immune system. And so that's how I explained it to the reporter, and that's how I think through it. I'm not concerned about my NMO patient population getting coronavirus vaccines in any way that's different from the flu vaccine. And as you all know, if you're on Facebook, I often explain that patients who get vaccines can trigger a relapse. So there's components in the vaccine that are designed to stimulate the immune system. And in a patient who has an overactive immune system, that's not a good thing because that can trigger a relapse. You want to generally keep the immune system calm, and immune stimulants are generally not a good idea. But it's a balance of risk, okay? And so if there's a vaccine you have to have, like coronavirus or something else that's going to save your life, then you might want to take that risk rather than risk getting the infection. And then the infection will not only harm you, but it'll also trigger a relapse at the same time. And so that's the balance of risks I'm talking about. The nice thing about NMO is in our study, if you are on treatment, on preventive treatment to prevent relapses, it also mitigates the risk from a vaccine. So all of our patients who are on rituximab, for example, or who are on Cellcept for NMO, when they were vaccinated to flu or diphtheria or any of the other commonly used vaccines, they did not have an association with the vaccine. They did not have an associated relapse. And so we feel like if you're on treatment, that's relatively safe and you can go ahead and get your vaccines that you need. For those of you who've had relapses right after a vaccine, I understand that you don't want to go get it. I get that. Do I think it's safe in that context? Maybe that's a good reason not to get the vaccine. That's a decision you're going to have to make. But again, the balance of risk suggests that if you avoid the vaccine, but then you get the infection, that might stimulate your immune system even more than the vaccine would. And so you have to consider these things. Now, if everyone around you gets vaccinated and you're protected by herd immunity, that's great. But if you work and you're out there and you teach kids and they're germ factories and you're out there working at the grocery store, in the hospital, or whatever, and you're exposed to all these germs, you have to consider whether you prefer the risk from the vaccine or take your chances and deal with the risks of the infection itself. So that's what you have to weigh in your mind. Okay, so the vaccines, when they come out, I don't know if they will have adjuvants in them. I have not seen any of that information. I can tell you the new flu vaccine that's out, the one I just got in my arm last week, does not have any adjuvants. It's simply recombinant proteins from, or extracted viral proteins from 2 strains of flu A and 2 from flu B, 2 different types of strains. And there's no adjuvant. And the CDC doesn't feel like you need an adjuvant for this particular strain of flu. And so it's basically just virus grown in eggs and extracted, injected into your arm. So if you don't have an egg allergy, it should be safe, again, assuming you are on preventive therapy. There is what's called a double dose, I believe, double dose flu vaccine that also contains not only twice the amount of flu protein, but also thimerosal adjuvant. And that's really designed for people who have very poor immune systems or older folks whose it takes a little bit more to get their immune systems activated. That's what that vaccine is designed for. And I do not recommend that for our patients. I think that you're probably fine to just get the regular flu vaccine, and then assuming, again, that that's something you're going to do, that it would also be, we'll have to evaluate the coronavirus vaccines to see what kind of adjuvants they have and if they're safe for NMO patients. Okay, so what else is going on with coronavirus? Well, we have a certain level of risk that everybody has, okay, to just acquire the illness. And we don't know necessarily if there's anything, demographically based that makes you more or less likely to get the infection. We know risk factors that predict a poor response, okay, a poor outcome. We know older age, especially over age 80, and every decade over age 40 imposes more and more risk of a bad outcome. So age is like the strongest risk factor we have, but so is obesity. I think that's number 2. Okay, and then number 3, I think, is diabetes and hypertension. And somewhere on that list is baseline neurological disability and immune compromised state. Now, the immune compromised state includes everybody whose immune system is compromised, whether it's through chemotherapy because you had cancer treatment, or maybe you had a transplant, like a solid organ transplant, a kidney transplant, and you're on immune suppressive medications. It's all those people plus the rheumatology population, and it just includes everybody. And so it's in Italian studies at the onset of the pandemic, immunocompromised state imposed a 2 times higher risk of a bad outcome, but we don't really have a breakdown of who those people were. Were they cancer patients? Were they old? Were they autoimmune patients? We didn't really know. What has emerged over time is MS patient populations, multiple sclerosis patient populations who are on the same drugs as a lot of my NMO patients. So they're on Ocrelizumab, which is a form of CD20 B cell depletion therapy like rituximab. Okay, so we have patients who have multiple sclerosis, may have some baseline disability from that multiple sclerosis, and they're on B cell depletion therapy. And for the most part, those patients are not adversely affected. They don't necessarily predispose to getting the infection. And even when they get the infection, there's no strong risk for a bad outcome. Even when they're on those B cell therapies. So among about 150 patients with multiple sclerosis who were on B cell therapy, about 5 had a bad outcome, which is about even with the general population. And those 5 were all older, and they were not even on treatment anymore. And they were already severely disabled, and maybe they couldn't breathe as well or cough as well as younger people with MS. And this is held true throughout other populations. It first came out of Italy, and China also published a large series. They have a lot more NMO as a percentage of their demyelinating disease. So they had 3,000 NMO cases, of which only 2 out of those 3,000 even tested positive for the coronavirus. Now, I don't know how, I didn't quality check that data coming out of China, but suffice it to say, in that patient population from China with NMO, there was very little risk. And those patients were on all kinds of treatments like azathioprine and tocilizumab and prednisone and things like that. And they seem to be okay as well. So there's nothing in the literature right now that makes us particularly worried for NMO, MOG, TM, ADEM, MS patients, in particular for coronavirus. We recommend taking all the usual precautions as everybody else would, not just for yourself, but to avoid spreading it to others in case you are infected. And we even have some anecdotes. This was very interesting. We have some anecdotes of NMO patients whose whole families were affected by coronavirus. Laid out, sick, breathing difficulty, the whole thing. Kids are sick, everybody's sick. But the NMO patient herself is actually not very sick at all. And she was on immune suppressive therapy. And so a lot of the thinking around the illness of coronavirus illness relates to the immune activation that results from it. So a lot of the problem with the infection is the immune system itself that's being driven or hyperactive and causing a lot of trouble. And we know a lot of the mortality comes from immune overactivation as well as blood clots that can form as a result. And a lot of other infections, like in the heart, for example, when the infection affects the heart muscle tissue itself, then that can cause a lot of complications too. So overall, nothing scary in terms of the NMO patient population or MS population or TM and MOG, optic neuritis, and so on. Okay, I'm going to just pause for a second so I can look at some of the questions and see if there anything that I can discuss. Okay, there was one question about other vaccines like flu vaccine and the potential to trigger an optic neuritis in a MOG patient. A lot of MOG patients are not yet on therapy or may decide not to go on therapy, on preventive therapy. We don't have great therapies. We have IVIG and CellCept and a few other things. And a lot of MOG patients are like, well, I've only had one attack and I tested positive for MOG and I'm going to wait for a second attack to see if I even have a relapsing disease. Or maybe I did and I had 2 minor attacks and I'm just going to take my chances and treat the relapses when they occur, but I don't want to go on some daily or chronic preventive therapy. And so there are a lot of MOG patients who are not currently on treatment, and that's their decision. They understand the balance of risks. What about a vaccine for those patients? I would say that that's one of the highest risk populations is someone who's capable of mounting an immune reaction to something like a vaccine or infection and not having any medication on board to tamp it down. So I would say if you're any antibody positive and you're not on preventive treatment, that you are among the highest to have a reaction to any vaccine. And that would be true of flu and coronavirus. Okay. Is it possible to have reactions to the shot because of NMO? Yeah, so NMO is thought to be specifically neurological. Okay, so you don't necessarily have immune reactions to other things. You shouldn't get rashes more easily or joint issues or things like that unless you have a concurrent autoimmune disease like lupus or something like that. But if you have just NMO and you get the shot, then if you're going to have an immunological side effect from it, it might be an NMO relapse, but it's not necessarily going to be something else immunological like Guillain-Barré or something like that. So you're either going to get an NMO attack or you're not. And if you're on preventive treatment, the thinking is that you hopefully will not have a relapse after a vaccine. Okay, thoughts on kids going back to school? Thanks a lot, Ms. Richardson. That is a very contentious topic. I think it depends. Right now, I wish my kids were back in school so that I could actually get some work done. But it's not all about us, right? We have to consider kids. We have to consider their health. We have to consider whether they're going to transmit or spread the infection community-wide, whether they're going to transmit it to teachers who are older, and whether they're going to bring it home and transmit it to parents and grandparents. It's a lot to consider. I think the data suggests that kids who are infected don't have as bad outcome as older folks. Like I said, with every decade of age, outcomes are poorer. Doesn't mean that kids always have good outcomes. They don't. There are a handful of kids who've had bad outcomes, and they are potentially preventable. So what if we mitigate some of the circumstances around spreading coronavirus? I can tell you in my neighborhood right now, the kindergartners are back in school. They try to maintain 6 feet between the kids at all times, even on the playground. They try to keep them, I don't remember if they are required to wear masks or not. The thought is that older kids should be able to keep masks on their faces, try to keep their hands to themselves. I have 3 kids. I've been harping on them to follow all these precautions. When they're with their friends, I don't know what they're going to do. I think they're much, much harder to train than the general adult population. But, if these things were possible, then maybe kids could go back to school in a very safe way. It's just a lot of precautions to take. Then the other major issue here is ventilation, because the CDC has been kind of going back and forth on whether coronavirus can be aerosolized. Aerosolized basically means that me talking right now creates virus particles that can float around in the air and stick to things and hang around for a while. And so if somebody else comes and does another a Facebook Live podcast after me and sits in this very chair, maybe they'll breathe in the droplets that just came out of my mouth, and then they'll get infected. That's what aerosolized means. And the CDC has been kind of going back and forth on whether coronavirus can be aerosolized. It's a political issue, and so unfortunately that means that it contaminates the science, and we don't even know the answer to that. The implication here for the schools, though, is that if they have better ventilation systems so they could filter that out, then maybe they can mitigate that risk. So one of the things that they're doing at my kids' school here is that they're upgrading all the ventilation systems so that those viruses could, even if they are aerosolized, could be filtered out. Okay, and then what are your thoughts? Oh, and one more thing about schools is there's this idea of creating a bubble. And a bubble is like a family. So that might be a whole classroom, for example, where all the parents agree that the kids would be exposed to each other within the bubble. And if anyone in the bubble tests positive for coronavirus, the whole bubble is quarantined. And then in that way, then you can try to maybe have more of a normal class as best as they can without trying to keep everybody so separated. So that's another option, but everyone would have to agree on this sort of bubble concept. I know in some neighborhoods, kids who are homeschooling are creating bubbles. So there may be 2 or 3 or 4 households and they all agree to be in a bubble. And if any of them get sick, well, then they'll just quarantine. So that may be possible in your neighborhood. Okay, what are thoughts about going out at all? Should we still be quarantined? A lot of it depends on how active the spread is in your area. So I live in New England. I live in one of the 5 states where trends are getting better every day, and where the test positivity rate has been less than 1% for a long time, in terms of several weeks already. So among everyone being tested, less than 1% are positive in the state of Massachusetts, as well as the surrounding states in New England. And I believe upstate New York as a state as well is in that less than 1% range. But my understanding is more than half of the rest of the United States is still well above that. They may be in the 5% range or so. And so that creates concern about continual spread of the virus. If we can get that under 1%, the feeling is you might be able to open up more of the economy, let people out, do their business, do whatever they have to do. But if the numbers start creeping up, then the idea is, you're putting people at risk unnecessarily. So maybe you're not at risk if you have NMO, but maybe somebody who just had cancers at higher risk, and you're putting them at risk, and it's a community effort. And so that might be a reason to remain quarantined. Just depends on where you are. The last I saw in the New York Times, the hot spot was like North Dakota, South Dakota. I don't know if I have any patients there or if anyone actually lives in those areas. I'm kind of joking, but those are the areas that are hot right now. And maybe in those areas, they should remain quarantined. Whereas maybe in New England, maybe we can continue to open up. Okay, there's a question here of a MOG patient, MOG seropositive patient who's on prednisone. And I'm going to change her question a little bit to make it relevant to the coronavirus. She's on prednisone, and prednisone is among one of the most potent immune suppressants. MOG patients are very sensitive to prednisone in a good way, in that if you start steroids during a relapse, you're likely to improve. But in a bad way, then it's hard to get the steroids off, because when you withdraw them, you can trigger another relapse. And MOG patients really often will get hooked on steroids, because as soon as you try to taper them off, they will relapse. And some of their symptoms may be pseudo-relapse, but it's so hard to tell. They often just go back up on their steroids. Weaning off of prednisone is a difficult task for MOG patients. So what about those folks who are on prednisone and their risk for coronavirus? I think I don't know. I haven't seen any data in that regard. I imagine it's probably among the more potent immune suppressants, but we're using steroids for those who get infected to prevent the worsening. So maybe if you're on prednisone, you're more likely to get the infection, but hopefully it also means on the other end of that you're less likely to die from it or have complications from it. I will say that I know of one NMO patient who was on prednisone living in the UK who was infected with coronavirus, and she did pass away. She was one of 2 patients I know of with NMO who died from coronavirus. Another patient was mine who had coronavirus and was in the hospital in a fairly well-controlled setting. The plan was to intubate her because she was slowly getting worse. During the intubation, she had a heart attack and passed away. And maybe that's in part because the coronavirus was affecting the heart tissue as well. Now we know that could happen. At the time, that wasn't even on the radar. So I know of 2 NMO patients who've passed away, one on prednisone, one on rituximab. And the rituximab patient is the one who had the heart complications. Okay, more questions on coronavirus. Let's see. Here's a question. For MOG NMO patients, do you view getting a flu shot as something you would generally recommend, strongly recommend, or something that you don't generally recommend? Okay, so here's the way I think about the flu vaccine for any individual. If you're on rituximab or good preventive medication, then the chance of a relapse after a flu vaccine is very, very low. And it's probably in your best interest to get the flu vaccine. Okay, so if you're on treatment, I recommend the flu vaccine. If you're not on treatment, I don't recommend the flu vaccine, because I'm worried that the flu vaccine or any vaccine can trigger a relapse. And so it's really whether you're on treatment or not that influences my decision or my recommendation to you about whether you should get the flu vaccine. Now, flu is generally a safe vaccine, and that influences my recommendation. If coronavirus vaccine is just as safe as flu vaccine, same general principles apply. But if the vaccine turns out to be a more potent vaccine, then we'll have to weigh things, because you don't want to trigger a relapse, and even if it provides you immunity against coronavirus, because it may be that the risks of the vaccine are greater than the benefits. That we'll have to see when the vaccines come out, what they're composed of and how strong the immune response is. A question, do we need to shield again as numbers of coronavirus cases rise? Again, if you're asking as general population, I think the idea is that for the public health, you want to try to limit the spread so that people who are vulnerable don't get the infection. Specifically for NMO, though, my view is that as long as you're taking precautions, the general precautions like face mask, don't touch your face 6 feet apart, that type of thing, I don't think that you're at any particular higher risk than any other person out there. So that's my answer about coronavirus and NMO patients. There's a question here about the pneumonia vaccine. So the Pneumovax is a pneumonia vaccine against a specific type of bug called pneumococcus. And that one is also very safe. It's a recombinant protein. Recombinant meaning they synthesize it in the lab. It's not grown up in a virus, broken apart and filtered and stuff. It's not like that. That's called either a live attenuated virus if it's still alive but unable to divide, or a dead vaccine if it's true virus and just killed off maybe by heat or chemicals. Those are much more potent at stimulating the immune system because there's so much for the immune system to process and react to. Recombinant vaccines, on the other hand, are a single protein. And what you try to do is you pick the protein that you really want the immune system to be tuned to. So for flu, the CDC goes through and picks out which proteins they want your immune system to react to because they feel like that would be the most effective and the safest. So Pneumovax is the same thing. It's a recombinant protein to pneumococcus, and it turns out to be very safe. It's right now only recommended if you're, I think, 55 years of age or older, but certainly, if you're in the hospital, we offer it to patients. If you're at risk, we offer it. So if you have the opportunity to take it and you want to, that's certainly fine. For anybody who's on Solaris, Satchelisumab, that's a complement system blocker. Complement is required to fight off that infection. So if you are on Solaris, I do recommend that you use the pneumococcus or Pneumovax vaccine. Now, the new shingles vaccine, Shingrix, is also a recombinant protein, and it is also among the safer vaccines. Now, it does contain an adjuvant. The Shingrix vaccine is the first one in the US to use a vaccine that comes from, I forgot the name of the tree. It's a very special tree that grows in Chile, in South America. And there's an extract from the bark. So it's all it is. It's just an extract from the bark of a tree that grows in Chile. And it's a very effective vaccine. It's among the most effective vaccines that we have in the US. And, we haven't seen a lot of complications from it. So this adjuvant in particular is being developed for tons of other vaccines now because it seems to be effective and safe. So Shingrix safe, pneumococcus safe, flu safe. Those are the big three that a lot of my NMO patients ask about. Okay, now what about timing? I told you that if you're on preventive treatment, it's generally safe to get a flu vaccine or another vaccine. What about timing relative to when you're getting your treatment? So the thinking with rituximab is that you're not really treated and untreated in waves, okay? Even after your treatment, even after you get your treatment, you're no more protected at that point than you are 5 months later. If you have no B cells, you're basically protected from a relapse in NMO, and your immune system is basically at the same level as you get your next infection, next infusion, and so once you start rituximab, your immune system is basically stable after that. It doesn't fluctuate with infusions. You get a little bit of steroid dose with each infusion. That suppresses your immune system a little bit, but from the rituximab point of view, your B cells are always depleted and your immune system is basically stable, and that's where you get the protection. And so when you get your vaccine relative to the infusion is not that critical because your immune system is basically stable the whole time. Um, the one caveat is the steroid dose. So you get a lot of people get infusion related reactions to the rituximab infusion, and they get a little bolus of steroids, usually 125 milligrams of methylprednisolone, something like that. That might suppress your immune system a little bit, might also suppress your reaction to the vaccine. Now, what about the efficacy of a vaccine while you're on rituximab? The thinking is that rituximab suppresses your immune system just a little bit, not enough to make you, to put you at risk of weird infections or cancers or anything like that, but enough to affect the vaccine's efficacy. So if you immunize 100 people and let's say you get an efficacy level of say 80% are now immune to the product you're vaccinating against. Let's say that's your efficacy for your new vaccine. If you're on rituximab, you may blunt that response a little bit more so that 80% of those 80, or about 64, would be immune and protected, and the rest in between, that 16, who are then blunted from responding to the vaccine, that's the loss of efficacy imposed by rituximab. It's not a huge amount. We generally feel like in the balance of risks, it's safer to be on rituximab and try to mount a vaccine response rather than come off of treatment and mount a vaccine response. In multiple sclerosis, it's reversed. For those of you who have MS on the call, you'll know before you started your ocrelizumab, they made you get the vaccines ahead of time. They said you can't get the vaccines after ocrelizumab because they're worried they won't be effective. But in MS, they're more worried about the vaccine taking hold than in preventing relapses necessarily. And so they want all the vaccines ahead of time. In NMO, we avoid relapses at all costs. So you get the treatment first and maybe a slightly blunted reaction to the vaccine, but still better than nothing. And then you could always get a booster. You get a boost to whatever vaccine you're getting, Shingrix or whatever. You just get a booster shot later on, and that sort of boosts your response anyway. Okay. There's a question here about Solaris. Flu is a virus, and it invades cells. So the flu virus lives and spreads from within cells, and so the complement system doesn't have access to the inside of cells, and so the complement system is not involved in fighting the flu. Now, at the very end stage of coronavirus infections, during that whole immune activation syndrome, then complement gets involved and just starts causing lots of trouble. And actually, Solaris is being developed to treat those end stage coronavirus cases, and it might be helping with that. So we don't know, but basically, flu and coronavirus, they don't need the complement system to fight. The immune system doesn't need the complement system. And so if you're on Solaris, you need to get a meningococcus vaccine, pneumococcus, and most people have already been vaccinated for Haemophilus as a child. Those are the bugs we're most worried about. Viruses are not part of that system. But still, if you want to get the flu vaccine, you're certainly able to do that. Okay, let's see. More coronavirus questions are coming up. Okay, I do see a lot of kind of individual questions about, my case of NMO, MOG, whatever, and you're certainly welcome to email me or Facebook me or whatever, and I can try to answer individual questions. If you have more questions about coronavirus, please do post it. Okay, let me think of what else we have to worry about with coronavirus. What about the other treatments? We have new treatments that are approved for use in NMO. That includes Anabolism, which is a B-cell depletion drug like rituximab, but broader, targets a few other cells like plasmablasts that may be making the aquaporin 4 antibody. We obviously have no experience with Anabolism and coronavirus. These trials were completed very recently and just The drug was approved, I think, in June. So we just don't have enough information. If you extrapolate back from the rituximab data and ocrelizumab and other B-cell therapies, Anabolism does not seem to impose any additional risk. So Anabolism and coronavirus, that seems to be fine. The brand name for that is Uplizna, and I'll just remind you that that company that makes that drug helped the Sumaira Foundation sponsor this event, in full disclosure. The third drug that was approved is Satchelisumab. That's an interleukin-6 receptor antagonist. Now, what that means is it blocks communication through a chemical product called interleukin-6. If I gave you a shot of interleukin-6 into your bloodstream, it would induce a fever and a general pro-inflammatory response. It activates the whole immune system. It even pushes cells that are making aquaporin 4 antibody to make more aquaporin 4 antibody. And in that context, if you block interleukin-6, the thinking is you block communication among all those inflammatory processes, and you can improve outcomes. There were 2 trials that were run, one in the US and one worldwide, that demonstrated the benefit of Satchelisumab, and that was published and just recently approved as well. I don't have any data regarding coronavirus and that mechanism either. So interleukin-6, blocking interleukin-6 doesn't seem to predispose to coronavirus or impose a bad outcome. There are lots of studies going on about whether at the end stage of coronavirus, when the immune system is all activated, if you block interleukin-6 in that context, could you have a better outcome? So those studies are still ongoing. We don't know. We know that in other conditions of hyperimmune activation, that using IL-6 blockers is helpful. Again, that's just to temper the immune response once it goes awry. So we don't think necessarily that if you're on Satchelisumab, this new drug for NMO, that it imposes any additional risk during the coronavirus pandemic. Okay, so that's the new drugs. I do see a question here. My husband may have coronavirus and has been ordered to quarantine. And this person has a rituximab infusion coming up. And there's a question, is there an additional risk in getting the rituximab infusion? Now, the thinking behind quarantining at home is that if there's one person infected, could you potentially avoid spreading it to other people? And that there's some data on this that suggests that if you're really good about quarantining at home, so the person who's sick sleeps in a separate bedroom, and when they use the kitchen and bathroom, they wipe everything down in between, and they stay 6 feet apart and wear masks. So if you can do that, then for 14 days from the onset of the first symptom, then in theory, you could home quarantine and avoid getting other people sick in your family. And the numbers on that are about 20% risk of still passing on the infection. So 80% chance that if you quarantine yourself, that it'll work. 20% chance that you try your best and you still infect your family. And it might depend on the timing, right? Because by the time you get your first symptom, you're in the car with your loved one who's driving you to the clinic. You might all get infected early on anyway. So that's very difficult. But let's say your husband or wife works and acquired the infection somewhere else, got sick, came home, and then you have to go out for your rituximab infusion. Again, the day that you go for your infusion, the only real difference in that day is that you're getting an additional dose of steroids. But we don't really think that additional dose of steroids imposes any additional a significant risk. There might be some to getting the infection, maybe even in prolonging the course of infection, but not in having a bad outcome. Because we think if you keep the immune system calm, even during the infection, that leads to a better outcome than if you let it get all activated and overactivated. So if you're getting your rituximab infusion, you should go ahead and do that, even while you have somebody in your household who's self-quarantining. Now, it was kind of funny when I was at this Chelsea clinic. Chelsea is a very, very dense neighborhood, and there are a lot of multi-generational families who live in 2-3 bedroom condos and townhomes. And, we were giving them information to self-quarantine, and they kind of looked at us like, are you crazy? How am I going to self-quarantine? I take care of my grandkids, or when the parents go to work, it was impossible to self-quarantine in a lot of these families. And that's why it spread so quickly. And the thinking is similarly in Italy, where a lot of grandparents live with the grandkids and partake in family events. It's very difficult to self-quarantine. So if you can do it, it's fantastic. It's great. If you can't do it, you're like the Italian families that had trouble doing that as well. Okay, then there's a question about IVIG, intravenous immunoglobulin. A lot of patients are on it because they may have long-standing immune deficits from rituximab usage, or you might be using it for MOG antibody disease, where it's very helpful, or maybe after ADEM or recurrent ADEM. Generally, IVIG is not immune suppressive. So if you're on only IVIG, the thinking is you're not at higher risk at all. There was some hope that IVIG, which is a collection of antibodies from the whole population, in every dose of IVIG, there's a collection from 10,000 individuals at minimum of all their antibodies pooled into one bottle just for you. And you get that infusion. And the hope is, or was, that among those 10,000 people, maybe there were some who had the coronavirus infection, recovered from it, produced antibodies to it, and can then confer the immunity to you. That's the idea behind convalescent plasma, is that there's somebody who just fought off the virus, is making tons of antibody to it, and if you need it, then they can be infused into you. So IVIG is kind of like that, but just from 10,000 people at least. But it turns out most of those IVIG products were made months and months and years ago, and then processed over time. And so the chance that you're going to get an IVIG batch from something that was made in time to get patients who've recovered from coronavirus, chance is pretty low. So I wouldn't go out and get IVIG as a treatment for coronavirus, but it does seem to be safe and not harmful. And so if you're on IVIG, you can certainly continue that. Okay, and then I just got notice that there's time for one more question. So who's got the final question? If nobody sends me a question, I'm going to make something. Okay, final question. Okay, there's one question here that's not going to be the final one. It's the comment on the report of transversemyelitis in the AstraZeneca phase 3 trial. You have to go back to the earlier part of this video. I think it'll be posted, and I did talk about it. So I won't make that one the final question, but if anyone else has one more question before 1 o'clock. Again, if you have any individual thoughts, questions about your case or your kid's case, by all means, send them in. You can post them on our Facebook pages, or you can just Facebook Messenger me directly. Okay. All right, so I'm going to leave you with a final thought that, our worries at the beginning of this pandemic is that NMO patients would be particularly vulnerable to this infection, and that they would have immune activation, and it would be terrible for this patient population. Turns out that doesn't seem to be the case, that this one just kind of flew over us, over the NMO patient population in general, even though it hit everybody hard. It doesn't seem to be specific for NMO or MS or transverse myelitis. So in that sense, I feel like we're very fortunate, and I just want to thank everyone for their time and great questions. Thank you so much, everyone. Bye-bye.